Mrs. Hollis, I'm very sorry to meet with you under these circumstances. Thank you for coming. I know this is hard for you.
Yes, it is.
Mr. Hollis, thank you for coming. Our goal today is to do our best to answer all of your questions. There's no question off limits. Hello, John. We weren't expecting you, but we're glad you're here too. We're going to meet in this room here. I've assembled the care team to meet with you. Do you have any questions or concerns before we go in? Can I get you anything? A glass of water, a cup of coffee?
No, thank you.
Then if you're ready, we'll join the care team. Let me start with some introductions. This is Jason's father, Alex Hollis, and his mother, Linda Hollis. Of course, you both know cardiothoracic surgeon, Dr. Michael Stiver, and anesthesiologist, Dr. Wes Myers. This is nurse, Michelle Thornton, and you may remember cardiothoracic fellow, Dr. Megan Schaefer. Now that I've made the introductions, I'd like to start off by saying that Jason was important to all of us in this room, and we're genuinely sorry to be meeting with you under these circumstances. Your family, understandably, has questions and concerns, and we're here to do our best to answer those questions. Mr. Hollis, I'm aware that you have a personal issue that you'd like to address first. The fact that Dr. Stiver did not attend Jason's funeral. So we'll start with that and then move on to the rest of our discussion.
"18 years. You knew our son for 18 years, and yet you didn't make any efforts to come to his funeral. I thought he meant more to you than that."
Mr. Hollis, I want you to know first how much I cared about Jason. I was there when he was born, as well as when he died. I've operated on thousands of people, most of whom I never see again after that initial operation. But Jason was different. And the knowledge that he died under my watch is something I'll carry with me the rest of my life. I wanted to be there. But 2 years ago, I was booked to address a major medical conference out of the country. I couldn't get out of it, although I tried. Never in a million years, when I agreed to speak at this conference, did I imagine that I'd need to miss Jason's funeral as a result. No parent should ever have to bury their child. And I am just so sorry about that.
I guess we understand.
Does anybody have anything else they'd like to say about this issue? Okay, then let's move on to Jason's care. Mr. Hollis, I know you've questioned repeatedly why we recommended this operation. Dr. Stiver, could you please explain how important this surgery was to Jason?
Yes. When I first met with Jason several months ago to discuss replacing his heart valve conduit, I told him quite clearly, this is elective surgery. It does not have to be done right now. But every year we delay, the technical component of this surgery gets more difficult. Even now, I can say confidently it was the right medical decision to make. And if I were advising Jason today, I would make the same recommendation. Mr. Hollis, if you're beating yourself up over the idea that you let your son make the decision to have this surgery, please don't. It was my recommendation, and medically and statistically, it was the correct one.
What does that mean?
Every year, Jason continued to build scar tissue around his heart. The conduit that we put in at his birth was increasingly inadequate for his cardiac needs. The last thing we wanted was to weaken his heart because the conduit wasn't supplying enough blood. The conduit needed to be replaced when his heart was strong. I've been over and over this in my mind 1,000,000 times, and I would not do anything differently. Having this surgery was the right decision. And I, not you, was the one that impressed upon Jason the value of having the operation done sooner rather than later. I also want you to know we didn't take this surgery lightly. We studied every parameter of Jason's physiologic state, his ability to withstand the surgery, his blood pressure, and his strength. He was in perfect shape for this operation.
Well, did you check his cardiac ejection fractions?
Of course, as I just explained to Mr. Hollis, I addressed all physiologic parameters for Jason's suitability for this surgery, and that certainly included ejection fractions.
Oh, okay then. That's good.
Dr. Stiver, while you're talking, there are some other issues we need to review. Can you talk about how the surgery went and then what happened in the recovery room?
Yes, I can. It was a 7-hour surgery. Dr. Schaefer assisted me with opening Jason's chest. Once the retraction was complete, I chose the sutures and placed them myself. I cut the graft material myself and carefully placed it. To some extent, we were always working against the clock. The longer Jason's chest was open, the greater the risk for infection and greater the fluid loss. We don't rush, but we don't dawdle either. I've done this surgery many, many times before. I worked with Dr. Myers to increase Jason's blood pressure. I double-checked the sutures and my anastomosis. They were intact. So I stepped out of the room to tell you the surgery went well, and Dr. Schaefer was left to close.
Dr. Stiver, why didn't you leave Jason's chest open before he was reperfused?
We reperfused, restored the circulation to an appropriate pressure under direct observation. I was satisfied that there wasn't a leak. We couldn't reperfuse him completely with his chest wide open. He was losing fluid, and we didn't want to impair that tissue, and we also didn't want to risk infection. I was happy to let Dr. Schaefer close so I could update you that, as far as I was concerned, everything went very well.
I agree with everything Dr. Stiver just said. We cannot reperfuse when a patient's chest is wide open. You see, things are done gradually, and there are pros and cons to everything we do. Our goal is to restore stable blood flow and not invite infection or dehydration.
Okay. And Dr. Schaefer, what happened next?
I was the one who closed Jason's chest. I inspected the graft and sutures. Everything looked fine as I closed. I personally moved him from the operating room to the post-op recovery room, handed him off to the nurses, and finished my charting.
Like Dr. Stiver, I participated in both of your son's surgeries, so I was glad to see him in recovery. His vitals were good and he was stable. I was the one who sent word out that one of you could come back and see him.
I was at Jason's bedside doing an evaluation when you arrived, Mr. Hollis. And as you know, all of a sudden his vital signs dropped off entirely. I knew something very bad had happened to Jason, and the most likely cause was a bleed. I reopened his chest right then and there. Blood was pumping into his chest and I couldn't see the source of the bleeding. But I put pressure on the graft site and rushed him back into the operating room. We did our best to reestablish his pressures. I was physically trying to stop the bleeding while we gave him blood. When we finally cleared his chest, we could see that 2 of the sutures holding the graft in place had pulled through the vascular tissue.
You're sure it wasn't the graft?
Yes, I'm positive the graft was intact, but I could see where the sutures pulled through the tissue. Mr. Hollis, this was no one's fault. As you know, Jason's heart tissue wasn't normal, but who could have predicted that it would not have been strong enough to hold the sutures? It held its last conduit for 18 years, right? I can't tell you how awful I feel about this. And I really tried to save him.
Is everyone okay? Does anyone need a break? Okay. Then I'd like to address each issue that was raised individually through emails and ongoing conversations. And as I go through the list, please let me know if I've missed anything. First, was the surgery needed? Dr. Stiver has addressed this today. And after extensive review, we believe this surgery was reasonable and correct and was in the best interest of your son. 2, was the surgery expertly performed? Dr. Stiver is considered to be an expert in this type of surgery. We have reviewed Jason's care extensively, and we cannot find a single thing we would have done differently. 3, should the chest have been closed before Jason was reperfused? As you know, we've looked at this carefully, and I've been reassured this decision is in accordance with established guidelines. John, if you check with any cardiovascular surgeon who does this type of operation, I'm sure they'll say the same thing. 4, did we notice the bleeding fast enough, and was the resuscitation handled properly? Dr. Schaefer just described the heroic efforts she used to try and stop the bleeding. She could not have done more. So after reviewing Jason's care in great detail, we cannot see how we could have done anything differently or how we could have changed the outcome. Again, I'd like to say that although something terrible happened, we were all united in the same purpose, to heal your son. Is there anything anybody else would like to say? Additional questions for the medical team? We know this wasn't easy for you, but we hope that the information we provided today will help to resolve some of the questions and concerns you've had. And after you leave today, if you think of something that we didn't discuss, please do give me a call. We want to support you in any way that we can. And we all want to thank you for coming today. Team, thank you.
Mr. and Mrs. Hollis, I just want you to know how terrible I feel about what happened to Jason. My heart goes out to you. It was an honor taking care of Jason. He was such a special young man, and I will never forget him.
Thank you, Dr. Stiver. He thought the world of you, too.